Explain the concept of ventilation perfusion, VQ matching, and discuss the physiological significance of VU mismatch. What are the potential clinical consequences of significant VU mismatch in a patient with chronic obstructive pulmonary disease (COPD)? Answer: ventilation perfusion (VU) matching refers to the relationship between the amount of air that reaches the alveoli ventilation and the amount of blood that reaches the alveoli via the capillaries perfusion. Ideally, VU ratios should approach 1, meaning that ventilation and perfusion are balanced, allowing for optimal gas exchange. In COPD, due to airway obstruction and destruction of alveolar structures, VU mismatch is common. This occurs when areas of the lung receive ventilation but not sufficient blood flow (high VU) or receive blood flow without adequate ventilation (low VU). The physiological significance of VU mismatch includes impaired oxygenation and hypercapnia. Clinical consequences may include hypoxemia due to inadequate oxygenation of blood, resulting in cyanosis and potential organ dysfunction, increased work of breathing. The body attempts to compensate by increasing respiratory rate, leading to respiratory muscle fatigue. Core pulmonale, chronic hypoxia can lead to pulmonary hypertension and right heart failure. Describe the microanatomy of the alveolar capillary membrane and explain its role in gas exchange. What factors can impair this structure and how might this affect respiratory function? Answer: the alveolar capillary membrane consists of 3 primary layers: the alveolar epithelium, the interstitial space, and the capillary endothelium. This thin barrier facilitates gas exchange by allowing O and CO to diffuse between the alveoli and blood. Key roles include gas diffusion. The thinness, approximately 0.5 micrometers, of the membrane allows for efficient diffusion of gases. Surface area. The extensive surface area of alveoli maximizes gas exchange capacity. Factors that can impair the alveolar capillary membrane include pulmonary edema, increases the distance gases must diffuse, impairing exchange. Infection. Inflammatory processes can thicken the membrane and reduce surface area. Pulmonary fibrosis. Scarring of lung tissue can reduce compliance and surface area. Impaired gas exchange may lead to hypoxemia and hypercapnia, necessitating interventions such as mechanical ventilation or supplemental oxygen. Discuss the role of central and peripheral chemoreceptors in regulating respiratory rate and depth. How do changes in pH, CO, and O levels influence their activity? Answer: central chemoreceptors, located in the medulla oblongata, primarily respond to changes in pH and CO levels in the cerebrospinal fluid. When CO levels rise, hypercapnia, it leads to increased carbonic acid and decreased pH, stimulating the central chemoreceptors to increase respiratory rate and depth, enhancing CO elimination. Peripheral chemoreceptors, located in the carotid and aortic bodies, monitor arterial blood O, CO, and pH levels. A significant drop in O, hypoxemia, stimulates these chemoreceptors to increase ventilation. They also respond to acidosis and hypercapnia. In summary, increased CO stimulates both central and peripheral chemoreceptors, increasing ventilation. Decreased O primarily stimulates peripheral chemoreceptors, also increasing ventilation. Decreased pH activates both central and peripheral chemoreceptors, leading to increased breathing efforts. Mr. Thompson, a 65-year-old male with a history of heart failure and COPD, presents to the emergency department with increased shortness of breath and swelling in his lower extremities. Upon assessment, his arterial blood gas shows at EGF 7.28, POCO of 6 mHg, and PAL of 55 mHg. What should Mr. Thompson's healthcare team prioritize in his treatment plan, considering the implications of his ABG results? Answer: given Mr. Thompson's arterial blood gas ABAB results indicating respiratory acidosis EH 7.28, POCO 6 mHg, with concurrent hypoxemia, PAL 55 mHg, the healthcare team should prioritize supplemental oxygen. To address hypoxemia, oxygen therapy should be initiated cautiously to avoid exacerbating hypercapnia in COPD patients. Mechanical ventilation. If Mr. Thompson is unable to maintain adequate ventilation due to respiratory muscle fatigue or increasing CO levels, non-invasive positive pressure ventilation (NIV) should be considered to assist in gas exchange and reduce the work of breathing. Bronchodilators. Administration of short-acting bronchodilators e.g. albuterol to alleviate airway constriction and improve airflow. Diuretics. If heart failure is contributing to fluid overload, diuretics should be administered to manage pulmonary congestion. In summary, the healthcare team should focus on optimizing oxygenation, enhancing ventilation, and addressing underlying heart failure to stabilize Mr. Thompson's condition. Explain the oxygen hemoglobin dissociation curve and identify the factors that can shift this curve to the right or left. How do these shifts affect oxygen delivery to tissues? Answer. The oxygen-hemoglobin dissociation curve illustrates the relationship between the partial pressure of oxygen (POW) and the saturation of hemoglobin with oxygen (SOUT). A rightward shift indicates reduced affinity of hemoglobin for oxygen, while a leftward shift indicates increased affinity. Factors causing a right shift include increased Coe-Boer effect. Higher levels of carbon dioxide decrease hemoglobin's affinity for oxygen, facilitating oxygen release to tissues. Increased temperature. Higher body temperatures promote oxygen unloading in active tissues. Decreased pH acidosis. Lower pH reduces hemoglobin affinity for oxygen. Factors causing a left shift include decreased Co. Lower carbon dioxide levels enhance hemoglobin's affinity for oxygen. Decreased temperature. Cooler temperatures favor oxygen binding. Increased pH alkalosis. Higher pH levels increase hemoglobin's affinity for oxygen. Describe the structure and function of the tracheobronchial tree and its significance in respiratory health. What anatomical features contribute to the efficient conduction of air? Answer. The tracheobronchial tree consists of the trachea, primary bronchi, secondary lobar bronchi, tertiary segmental bronchi, and further branching into bronchioles. This structure is significant for conducting air to the alveoli while maintaining optimal conditions for gas exchange. Key anatomical features include ciliated epithelium. The respiratory epithelium, lined with cilia, helps trap and clear mucus and debris, protecting the lower airways. Cartilaginous rings. The trachea and primary bronchi contain C-shaped cartilaginous rings that maintain patency, preventing collapse during respiration. Smooth muscle. Surrounding the bronchi and bronchioles, smooth muscle allows for bronchoconstriction and bronchodilation, adjusting airflow based on respiratory demands. In summary, the tracheobronchial tree efficiently conducts air to the lungs while protecting and conditioning inspired air, playing a vital role in respiratory health. Discuss the phases of the cardiac cycle and how they relate to pulmonary and systemic circulation. What impact does impaired cardiac function have on respiratory health? Answer. The cardiac cycle comprises two main phases: systole, contraction, and diastole, relaxation. During systole, the ventricles contract, pumping blood into the pulmonary artery to the lungs and the aorta to the body. During diastole, the heart chambers relax, allowing for filling. The relationship between cardiac cycle phases and circulation includes pulmonary circulation. The right ventricle pumps deoxygenated blood to the lungs where gas exchange occurs. Systemic circulation. The left ventricle pumps oxygenated blood to the body tissues. Impaired cardiac function can lead to pulmonary congestion. Heart failure may result in fluid backing up into the lungs, impairing gas exchange and leading to pulmonary edema. Reduced cardiac output, decreased oxygen delivery to tissues can exacerbate respiratory issues and lead to compensatory mechanisms that may further strain respiratory function. Define hypoxemia and hypercapnia, including their causes and physiological effects. How do compensatory mechanisms work in response to these conditions? Answer. Hypoxemia is defined as abnormally low levels of oxygen in the blood, typically measured by a POW of less than 6 mHg. Causes include respiratory disorders, e.g., COPD, pneumonia, anemia, and hypoventilation. Physiological effects include increased heart rate. The body attempts to improve oxygen delivery. Increased respiratory rate, a compensatory mechanism to enhance oxygen uptake. Hypercapnia refers to elevated levels of carbon dioxide in the blood, indicated by a POCO greater than 45 mHg. Causes include impaired ventilation, e.g., respiratory muscle weakness, obstructive lung disease, and decreased lung surface area. Physiological effects include respiratory acidosis, co-reacts with water to form carbonic acid, lowering pH. Cerebral vasodilation. Increased Co levels can lead to increased cerebral blood flow, potentially causing headaches and alter mental status. Compensatory mechanisms include increasing respiratory effort to expel Co and renal adjustments to regulate bicarbonate levels, balancing acid-base status. Discuss the factors that influence the diffusion of oxygen and carbon dioxide across the alveolar capillary membrane. How do changes in these factors affect gas exchange efficiency? Answer. The diffusion of gases across the alveolar capillary membrane is influenced by several factors, including partial pressure gradients. Gas molecules move from areas of higher partial pressure to lower partial pressure. A greater difference enhances diffusion. Solubility of gases. Co is more soluble than O, thus it diffuses more readily even at low partial pressures. Surface area. Increased surface area of alveoli improves diffusion capacity. Conditions like emphysema reduce surface area, impairing gas exchange. Thickness of the membrane. Thicker membranes, due to edema or fibrosis, impede diffusion. Changes in these factors can lead to decreased gas exchange efficiency. For example, in conditions like pulmonary fibrosis, increased membrane thickness reduces the diffusion rate, potentially resulting in hypoxemia. Explain the mechanisms by which carbon dioxide is transported in the blood. How do changes in these transport mechanisms affect acid-base balance in the body? Answer: carbon dioxide is transported in the blood through three primary mechanisms. Dissolved Co. About 5.10% of Co is transported dissolved in plasma. Bicarbonate ions, HEA. The majority, 70% of Co, is converted to bicarbonate ions via the enzyme carbonic anhydrase within red blood cells. This process involves Co combining with water to form carbonic acid, which dissociates into bicarbonate and hydrogen ions. Carbamino compounds, approximately 2.25% of Co binds to hemoglobin and other proteins, forming carbamino compounds. Changes in these transport mechanisms can significantly affect acid-base balance. For example, increased co-production can lead to more bicarbonate formation, raising acidity, lowering pH, resulting in respiratory acidosis, impaired co-removal. Conditions like COPD reduce co-elimination, leading to accumulation, further altering acid-base status. Explain the pathophysiological changes that occur in a patient with chronic obstructive pulmonary disease, COPD, and discuss the role of long-acting bronchodilators in the management of stable COPD. Answer: chronic obstructive pulmonary disease, COPD, is primarily caused by long-term exposure to irritants that damage the lungs and airways, most commonly cigarette smoke. The pathophysiology involves chronic inflammation of the airways, lung parenchyma destruction, and mucus hypersecretion, leading to airflow limitation. In COPD, the airways undergo remodeling characterized by smooth muscle hypertrophy, goblet cell hyperplasia, and thickened basement membranes. This results in a reduction of the elastic recoil of the lungs and increased resistance during expiration, leading to air trapping and hyperinflation. Management of stable COPD involves pharmacological and non-pharmacological strategies. Long-acting bronchodilators, including long-acting beta-agonists LOBAs like salmeterol and long-acting muscarinic antagonists LOMAs such as tiotropium, are essential for improving lung function and reducing symptoms. These agents work by relaxing bronchial smooth muscle, enhancing airflow, and decreasing exacerbation frequency. According to the Global Initiative for Chronic Obstructive Lung Disease, GOLD guidelines, initiation of these medications is based on the severity of symptoms and exacerbation history. Additionally, pulmonary rehabilitation, smoking cessation, and vaccinations against influenza and pneumococcal disease are recommended to improve quality of life and reduce hospitalizations. Describe the pharmacological approach to managing an acute asthma exacerbation and the mechanism of action of each class of drugs used. Answer: acute asthma exacerbations are characterized by rapid onset of breathlessness, wheezing, coughing, and chest tightness, requiring immediate pharmacological intervention. The cornerstone of treatment during an exacerbation is the use of short-acting beta-agonists, SOBAs, such as albuterol, which act as bronchodilators. In addition to bronchodilators, systemic corticosteroids, such as prednisone or methylprednisolone, are indicated to reduce airway inflammation and prevent further deterioration. They inhibit the inflammatory response by interfering with the transcription of inflammatory cytokines. The National Asthma Education and Prevention Program (NEP) guidelines emphasize that corticosteroids should be given early in the treatment course for moderate to severe exacerbations. For patients who do not respond adequately to SOBAs, anticholinergics like ipratropium may be added to provide additional bronchodilation through muscarinic receptor antagonism. In cases of severe exacerbation with inadequate response to initial treatment, hospitalization and close monitoring may be required, with further options including high-dose nebulized medications and possibly non-invasive ventilation if respiratory failure is imminent. Mrs. Lee, a 55-year-old woman with amyotrophic lateral sclerosis ALS, is experiencing difficulty breathing and shallow respirations. Her pulmonary function tests show a progressive decline in vital capacity. What mechanical ventilation strategy should her care team consider, and why? Answer: in the case of Mrs. Lee, a 55-year-old woman with amyotrophic lateral sclerosis ALS, her progressive respiratory decline is indicative of neuromuscular impairment affecting her ability to maintain adequate ventilation. Given that ALS leads to respiratory muscle weakness, her symptoms of dyspnea and shallow breathing necessitate the consideration of non-invasive ventilation (NIV) as a first-line intervention. NIV, particularly bilevel positive airway pressure (BiPAP), can significantly alleviate respiratory distress by providing positive pressure support during inhalation and preventing airway collapse during exhalation. The initiation of NIV has been shown to improve gas exchange and reduce the work of breathing, ultimately enhancing the patient's quality of life. Monitoring of vital capacity is crucial as it can guide the timing of intervention and the decision to escalate to invasive mechanical ventilation if NIV is insufficient. Additionally, advanced directives should be discussed early in the course of her illness due to the progressive nature of ALS. The American Academy of Neurology guidelines recommend offering NIV to patients with symptomatic respiratory failure due to ALS as it prolongs survival and enhances comfort. Continuous monitoring of blood gases and regular assessments of her clinical status are essential to adapt her treatment plan as the disease progresses. Discuss the use of high-flow nasal cannula (HNC) versus invasive mechanical ventilation for patients with severe COVID-19 related respiratory failure. Include the risks and benefits of each approach. Answer: the management of severe respiratory failure due to COVID-19 presents unique challenges. High-flow nasal cannula (HNC) has gained popularity as an alternative to invasive mechanical ventilation in certain patient populations. HFNC delivers heated, humidified oxygen at flow rates that can reach up to 60 liters per minute, providing better oxygenation and reducing the work of breathing. The benefits of HFNC include improved comfort for patients, the ability to maintain some degree of spontaneous ventilation, and the reduced risk of complications associated with intubation and mechanical ventilation. Clinical studies indicate that HFNC may decrease the need for intubation in select patients, especially those with hypoxemic respiratory failure who do not exhibit signs of severe distress or alter mental status. The key is to closely monitor patients on HFNC for early signs of deterioration, such as increased respiratory rate, use of accessory muscles, or worsening hypoxemia, which may necessitate escalation to invasive ventilation. Conversely, invasive mechanical ventilation is warranted in patients with severe hypoxemia, alter mental status, or respiratory fatigue who do not respond to HFNC. The guidelines from the Surviving Sepsis Campaign and the Society of Critical Care Medicine emphasize the need for early intubation in patients with rapid clinical decline. What are the primary diagnostic criteria for community-acquired pneumonia (CAP) in an adult, and which clinical guidelines are used to assess the severity of pneumonia? Answer: the diagnosis of community-acquired pneumonia (CAP) in adults involves a combination of clinical, radiological, and laboratory criteria. Clinically, CAP is suggested by symptoms such as cough, fever, chills, dyspnea, and pleuritic chest pain. Physical examination may reveal abnormal lung sounds, such as crackles or bronchial breath sounds indicating localized consolidation. Radiographic evidence is crucial, with chest X-ray findings typically showing infiltrates or consolidation. The Infectious Diseases Society of America (IDSA) guidelines recommend a structured approach to diagnosis, which includes obtaining a thorough history and physical examination, followed by appropriate imaging. Sputum cultures, blood cultures, and rapid antigen tests can assist in identifying the causative organism, particularly in severe cases. To assess the severity of pneumonia and guide treatment decisions, the CUB-65 scoring system is commonly utilized. This clinical tool considers 5 criteria: confusion, urea nitrogen level equals 7 mol, respiratory recall 30 breaths per minute, blood pressure systolic 9 mmHg or ESOL equals 65 years. A CUB-65 score of 0-1 indicates low risk and outpatient treatment may be appropriate. In contrast, scores of 2 or higher suggest an increased risk of complications warranting hospitalization. Explain the pathophysiology of idiopathic pulmonary fibrosis (IPF) and outline the recommended diagnostic approach. Answer: idiopathic pulmonary fibrosis (IPF) is characterized by progressive lung fibrosis leading to deterioration in lung function and quality of life. The exact cause of IPF remains unknown, but it is thought to involve repeated injury to the alveolar epithelium, leading to abnormal repair processes. This results in excessive deposition of collagen and other extracellular matrix components, causing architectural distortion of the lung tissue. Diagnosing IPF typically requires a combination of clinical assessment, imaging, and sometimes lung biopsy. The standard approach involves high-resolution computed tomography (ITIA), which may reveal characteristic patterns such as reticular opacities and honeycombing, particularly in the peripheral regions of the lungs. The American Thoracic Society and the European Respiratory Society (ERS) guidelines recommend a multidisciplinary approach for diagnosis, incorporating clinical history, radiological findings, and, when necessary, histopathological confirmation through surgical lung biopsy. Lung function tests (PFTs) often demonstrate a restrictive pattern characterized by reduced total lung capacity (TLC) and forced vital capacity (FVC) with a preserved or increased forced expiratory volume in 1 second. FEV to FVC ratio. Mr. Martinez, a 50-year-old construction worker with a 20-year history of asbestos exposure, presents with dyspnea and a dry cough. His chest X-ray shows diffuse pleural thickening. What is the likely diagnosis and what further steps should be taken? Answer: in the scenario involving Mr. Martinez, a construction worker with significant asbestos exposure, the clinical findings are dyspnea, dry cough, and diffuse pleural thickening on chest X-ray strongly suggest a diagnosis of asbestosis. Asbestosis is an interstitial lung disease characterized by pulmonary fibrosis due to inhalation of asbestos fibers, leading to progressive respiratory impairment. The initial steps in managing Mr. Martinez should include pulmonary function testing (PFT) to assess the extent of functional impairment, which typically shows a restrictive pattern with reduced lung volumes. High-resolution computed tomograph (ATT) is also essential for a detailed evaluation of pleural changes and lung parenchyma. Given the occupational history, it is crucial to establish a link between exposure and disease, which can be supported by the patient's work history and imaging findings. Furthermore, according to Occupational Safety and Health Administration (OSHA) guidelines, Mr. Martinez should be advised to avoid further exposure to asbestos and any other respiratory irritants. Although there is no cure for asbestosis, management strategies focus on symptomatic relief and monitoring for potential complications, including lung cancer and mesothelioma. Describe the pathophysiological mechanisms underlying acute respiratory distress syndrome (ARDS) and the recommended ventilation strategy. Answer: acute respiratory distress syndrome (ARDS) is characterized by rapid onset of hypoxemia and bilateral pulmonary infiltrates in the absence of heart failure, typically following a precipitating event such as pneumonia, sepsis, or trauma. Management of ARDS focuses on supportive care, with the primary goal of optimizing oxygenation and ventilation. The application of low tidal volume ventilation is a cornerstone in the management of ARDS as it reduces ventilator-induced lung injury. Current guidelines recommend maintaining tidal volumes of CLG of predicted body weight and employing a plateau pressure of less than 30 centimeters (HA). In cases of severe ARDS, the use of prone positioning has been shown to improve oxygenation and reduce mortality by redistributing perfusion and enhancing lung recruitment. In cases of refractory hypoxemia, extracorporeal membrane oxygenation (ECMO) can be considered as a salvage therapy for patients who do not respond to conventional ventilation strategies. Continuous monitoring of hemodynamics and organ function is vital throughout management, allowing for timely adjustments in therapy based on the patient's evolving clinical status. Mr. Kim presents with excessive daytime sleepiness, loud snoring, and witnessed apneas during sleep. Given his obesity, what steps should be taken to evaluate and manage his condition of obstructive sleep apnea (OSA? Answer: Mr. Kim's case presents a classic example of obstructive sleep apnea (OSA) characterized by recurrent episodes of upper airway obstruction during sleep. This condition is often associated with obesity, and his symptoms of excessive daytime sleepiness, loud snoring, and witnessed apneas are highly suggestive. The initial step in evaluating Mr. Kim involves a comprehensive sleep history and potentially a home sleep apnea test (HSAT) or in laboratory polysomnography. The apnea-hypopnea index (AHI) derived from these studies will help classify the severity of OSA, guiding subsequent management. AHI values of 5.15 indicate mild OSA, 1.53 moderate OSA, and greater than 30 severe OSA. Given his obesity, lifestyle modifications such as weight loss, positional therapy, and avoidance of alcohol and sedatives are critical first-line interventions. Continuous positive airway pressure (CPAP) therapy remains the gold standard for treatment in moderate to severe cases of OSA, as it provides positive airway pressure to maintain patency of the upper airway during sleep. Education regarding CPAP usage, including adherence strategies, is essential for effective treatment. Regular follow-ups are necessary to monitor his response to treatment and to adjust management strategies accordingly. A patient suspected of having tuberculosis (TB) presents with a persistent cough, night sweats, and weight loss. What diagnostic tests should be conducted to confirm the diagnosis of TB, and what is the standard treatment regimen recommended? Answer: the diagnosis of tuberculosis (TB) requires a multifaceted approach, beginning with a thorough clinical assessment of symptoms such as persistent cough, night sweats, fever, and weight loss. A chest X-ray is typically the first imaging study performed, which may reveal cavitary lesions or consolidation in the upper lobes, classic signs of pulmonary TB. Microbiological confirmation of TB is essential for diagnosis. Sputum smear microscopy, culture, and molecular tests such as the GenExpert MT-BRIF assay are utilized to detect Mycobacterium tuberculosis. The World Health Organization, WHO, recommends the use of a combination of these tests to increase diagnostic yield. Sputum culture, despite being time-consuming, remains the gold standard for confirmation and susceptibility testing. Management of TB consists of a standardized treatment regimen of first-line antitubercular medications, typically isoniazid, rifampin, ethambutol, and pyrazinamide for the initial 2 months, followed by isoniazid and rifampin for an additional 4 months. Directly observed therapy is recommended to enhance adherence and monitor for potential side effects. Regular follow-up assessments, including clinical evaluation and sputum tests, are essential to ensure treatment efficacy and monitor for drug resistance. Discuss the implications of the Health Insurance Portability and Accountability Act (HIPAA) for respiratory therapists in managing patient information. How should a therapist balance the need for confidentiality with the need for information sharing among healthcare team members? Answer: HIPAA mandates strict guidelines for the protection of patient health information. Respiratory therapists must ensure that all patient information is kept confidential and shared only with authorized personnel. To maintain confidentiality, therapists should limit access, only share PHI with team members who are directly involved in the patient's care, use secure channels, communicate sensitive information through secure methods, avoiding unencrypted emails or texts, educate staff, regularly train staff on HIPAA regulations and the importance of safeguarding patient information. When sharing information for care coordination, therapists should follow the minimum necessary standard, ensuring that only the information essential for the purpose is disclosed. This balance is crucial to uphold patient rights while facilitating effective care. What are the ethical implications of a respiratory therapist encountering a patient who wishes to discontinue mechanical ventilation but is not competent to make that decision? How should the therapist approach this situation while respecting patient autonomy and adhering to ethical standards? Answer: in this scenario, the therapist faces a complex ethical dilemma. The principle of patient autonomy emphasizes the patient's right to make informed decisions about their care, but competence is a prerequisite for such decisions. The following steps should be taken. Assess competence. Determine if the patient is indeed incompetent to make decisions. If not, the patient's wishes should be honored. Involve surrogates. If the patient is incompetent, refer to advance directives or consult with a surrogate decision maker such as a family member to understand the patient's preferences. Ethics consultation. Engage in ethics committee if disagreements arise regarding the discontinuation of care. Document decisions. Ensure that all discussions and decisions are thoroughly documented in the patient's medical record. This approach respects the patient's rights while ensuring that ethical and legal standards are upheld in the decision-making process. A respiratory therapist realizes they have administered a higher dose of a medication than prescribed. What steps should the therapist take in accordance with professional standards, and what are the potential legal ramifications if the error is not reported? Answer: the therapist should adhere to the following steps. Immediate action. Assess the patient for any adverse reactions and provide necessary medical intervention. Notify supervisors. Inform the supervising physician and relevant nursing staff immediately about the medication error. Document the incident. Accurately document the error, patient response, and the steps taken in the patient's medical record. Reflect on practice. Engage in self-reflection to understand how the error occurred and implement strategies to prevent recurrence. Failure to report the error can lead to legal ramifications, including potential malpractice claims. In some jurisdictions, not reporting medication errors can be seen as negligence, exposing the therapist to disciplinary actions from regulatory bodies, along with civil liability. How should a respiratory therapist navigate the ethical complexities of a patient who has a do not resuscitate DNR order but is experiencing respiratory distress? Discuss the considerations and actions the therapist should take. Answer: in the presence of a DNR order, the therapist must respect the patient's wishes while providing appropriate care. Key considerations include: understand DNR implications. A DNR order means that resuscitation should not occur, however, it does not preclude all forms of treatment, including palliative measures. Communicate with the care team. Discuss the situation with the healthcare team to ensure that all members are aware of the DNR order and the current condition of the patient. Provide supportive care. Administer treatments that alleviate discomfort and improve quality of life, such as oxygen therapy or medications for anxiety. Document interventions. Clearly document all care provided, the rationale for interventions, and any discussions held with the care team and family. By adhering to these considerations, the therapist upholds ethical standards and respects the patient's autonomy. A respiratory therapist is part of a multidisciplinary team caring for a patient with complex respiratory issues. What strategies can the therapist employ to ensure effective communication and collaboration among team members? Answer: effective communication and collaboration are critical in a multidisciplinary team setting. The therapist can employ the following strategies: regular team meetings. Participate in or initiate regular meetings to discuss patient care plans, progress, and any changes in the patient's condition. Utilize SBAR technique. Implement the SBAR situation background assessment recommendation communication tool to present patient information succinctly and effectively. Foster relationships. Build professional relationships with team members to enhance trust and collaboration. Advocate for the patient. Be proactive in advocating for the patient's needs and preferences during team discussions, ensuring their voice is heard in the care process. These strategies enhance teamwork and improve patient outcomes through coordinated care efforts. Mr. Thompson is a 72-year-old patient with chronic obstructive pulmonary disease, COPD, who is currently on a ventilator. He has a living will that states he does not wish to be placed on a ventilator if he is in a terminal condition. His family is urging the respiratory therapist to continue aggressive treatment. How should the therapist handle this situation while respecting Mr. Thompson's wishes? Answer: the respiratory therapist should take the following steps. Review the living will. Confirm the specifics of Mr. Thompson's living will to understand his wishes regarding ventilator use. Communicate with the family. Discuss Mr. Thompson's wishes with his family, explaining the implications of the living will and the importance of honoring the patient's autonomy. Engage the healthcare team. Collaborate with the physician and palliative care team to ensure that care aligns with Mr. Thompson's wishes, providing support for both the patient and the family. Document conversations. Document all discussions with the family and the healthcare team regarding Mr. Thompson's care and decisions made. By following these steps, the therapist respects the patient's rights and ensures ethical care is maintained. What are the ethical considerations a respiratory therapist should keep in mind when conducting research involving human subjects, particularly regarding informed consent and the use of vulnerable populations? Answer: ethical considerations in research involving human subjects include informed consent. Ensure that participants are fully informed about the research purpose, procedures, risks, and benefits before they agree to participate. This includes providing information in an understandable format. Vulnerable populations. Exercise heightened care when involving vulnerable populations, such as children or individuals with cognitive impairments. Obtain consent from legal guardians when necessary. Minimize risk. Design research to minimize risks to participants while maximizing potential benefits. Ensure that ethical review boards approve the study. Confidentiality. Maintain the confidentiality of participants' information throughout the research process and after its completion. Adhering to these ethical standards is critical to conducting responsible and respectful research. Discuss the role of continuous professional development for respiratory therapists in maintaining competence and adhering to ethical standards. What specific actions should therapists take to fulfill this responsibility? Answer: continuous professional development (CPD) is essential for respiratory therapists to maintain competence and adhere to ethical standards. Therapists should engage in lifelong learning, participate in workshops, seminars, and continuing education courses to stay updated on the latest practices and technologies in respiratory care. Seek certification renewal, pursue recertification and advanced certifications in specialized areas of respiratory therapy, ensuring that skills are current. Participate in peer review. Engage in peer review processes to receive constructive feedback on practice and improve clinical skills. Stay informed on ethics. Regularly review ethical guidelines and best practices to ensure compliance and understanding of professional conduct. These actions demonstrate a commitment to professional growth and accountability. How can a respiratory therapist effectively advocate for a patient's needs within a multidisciplinary team, particularly in situations where there may be conflicting opinions about the best course of treatment? Answer: advocating for a patient's needs within a multidisciplinary team involves several key strategies. Understand the patient's values. Clearly articulate the patient's values and preferences in discussions, ensuring these are central to the decision-making process. Use evidence-based practice. Support advocacy with evidence-based practices, presenting data and research that align with the patient's treatment goals. Facilitate open communication. Encourage an open dialogue among team members to discuss differing opinions, emphasizing a collaborative approach to care. Remain professional. Maintain professionalism even in the face of disagreement, focusing on the best interests of the patient and fostering a cooperative team environment. Through these methods, the therapist can effectively advocate for the patient's needs while promoting team cohesion. In what ways can respiratory therapists uphold patient rights while navigating the complexities of informed consent in cases where patients may have limited decision-making capacity? Answer: respiratory therapists can uphold patient rights in cases of limited decision-making capacity by assessing decision-making capacity, conduct a thorough assessment to determine the patient's ability to understand and make informed decisions about their care, involving surrogates, engage family members or legally appointed surrogates in discussions about the patient's care when the patient cannot make decisions, utilizing advance directives. Respect and follow any advance directives the patient may have established, ensuring that care aligns with their expressed wishes. Provide information. Simplify information and communicate in clear terms, allowing the patient to understand their options as much as possible, thereby respecting their autonomy. By taking these steps, therapists can ensure that they respect patient rights while providing necessary care.